what we're here to talk about is a device called the Watchman Device, which is a device that kind of brings on this new era in stroke reduction and atrial fibrillation. So we'll talk a little bit as the slides go on about kind of what atrial fibrillation is. I'm not going to spend too much time on that. Talk about the risks with atrial fibrillation, and then finally focus some time on speaking with the device. I do this procedure along with one of my partners, Dr. Tiongson, who some of you may be familiar with. He and I have actually known each other for about 20 years. We did the first phase of our medical training together, and we go way back. So it's fun to kind of be able to practice with him now. And so Watchman kind of falls in this kind of intersection category between interventional cardiology and electrophysiology. And that's why it's great that we can both work together to help our patients kind of benefit from the technology. So that will be kind of what we talk about. As Chelsea had mentioned, if you have questions, we have the chat box on the side that we're monitoring also, in the Q&A, and then I'll address questions kind of towards the end. And as we go along, if you can make sure that you're on mute so we won't get kind of weird feedback loops and dogs barking and stuff in the background, that'd be great. So to kind of get started here, as I mentioned, so we'll talk about kind of an overview. So what is atrial fibrillation? And then more specifically, kind of get into a little bit more of the complications of atrial fibrillation, talk about some traditional therapies, and then we'll focus a great deal of time kind of speaking about the Watchman device itself. So this is just kind of a slide to kind of demonstrate what atrial fibrillation is. When I talk to my patients, I kind of discuss atrial fibrillation as kind of a disordered array of the electrical activity. So you have two chambers on the top of the heart. So I kind of think of the heart like a house with two rooms on the top, two rooms on the bottom. So normally the right upper area of the heart, or what's called here on the left panel here, the sinus node, is the manager. That's where the heart gets the initial electrical impulse to beat. And it goes from that top right down to the bottom left area of the heart through the normal conduction system. And for whatever reason, either with age or thyroid issues or heart valve issues, or sometimes even something like sleep apnea that you may have heard of before, the electrical activity in that top right chamber gets some disorder to it. And you have thousands of little areas in the top chamber of the heart that are trying to initiate an electrical impulse to push that electrical activity through. Sometimes those waves kind of come together and cancel each other out. Sometimes they come together and form bigger waves. And so because you've got these thousands of different areas trying to initiate this heartbeat, excuse me, you get this very irregular pattern of blood flow, and that's irregular pattern of heartbeat, and that's what we call atrial fibrillation, or an irregular signal of activity. Now electrically, you can have these thousands of signals that are kind of coming and going. Mechanically, though, the heart tissue is not able to contract and expand with all those thousands of electrical inputs. So what ends up happening is those top chambers kind of get into this very kind of tense contractile state, and basically they become functionally paralyzed. So the top chambers of the heart are not moving in the same synchronization that we would expect in a normal circumstance. And as a result, what can happen is if those top chambers aren't mechanically contracting, the blood kind of pools along the walls of the heart and can form blood clots. And so we'll kind of talk about that a little bit more. Now, Afib is a growing problem in society, and it is associated with a high what's called morbidity and mortality, meaning people can have symptoms or consequences of the Afib, but unfortunately, they can actually also die a little bit quicker with atrial fibrillation in certain circumstances. So Afib is the most common arrhythmia or abnormal heart rhythm that we see clinically, and as our population of Americans gets older, we see that incidence or that burden of Afib kind of continue to rise with each decade of age. There's a higher risk of stroke with Afib, and about 15 to 20% of all strokes are related to atrial fibrillation. And strokes that are caused by Afib actually cause a lot more debility and disability than strokes not caused by atrial fibrillation. So this is kind of a big deal. And people that have Afib have a high risk of recurrent strokes, which is why we want to treat patients a little bit more aggressively. So this is just to kind of give an understanding, or at least some images here to kind of look at in regards to the anatomy of what we're looking at. And in particular, kind of on the top left chamber of the heart, this is my heart model, you have this outpouching here, this windsock called the left atrial appendage. Now, functionally, we'll get into what the left atrial appendage does, But from an AFib standpoint, what happens is that little outpouching, that little alcove in the top left chamber of the heart is where about 90% of the blood clots in atrial fibrillation that go on to cause stroke actually form. So when we're treating patients with blood thinners for atrial fibrillation, we're trying to limit or reduce the amount of blood clot that can form inside of the heart, 90% of which comes from this little wing-shaped structure called the left atrial appendage that you can see here in the pictures. Oh, and let me go here. And furthermore, kind of when we talk about the left atrial appendage, there's actually a couple of different anatomies here of what the shape of the left atrial appendage can look like. And this is literally what we describe them as: windsock, cactus, chicken wing, cauliflower. I think that the docs, when they did this, were kind of hungry, when they name this. But there are different shapes to this anatomy, and that becomes important kind of as we talk furthermore about the device. So I mentioned kind of this left atrial appendage, this kind of functional outpouching of the heart. Well, what does it do? Well, best we can tell, there's really one feature to this, or one function to it, is that it helps regulate the thirst mechanism. So it's kind of like a pressure sensor inside of the heart to know if the tank is full or if it's empty. And then it will send out this signal or a hormone called atrial natriuretic peptide, or a natriuretic factor, that initiates that thirst mechanism. And so part of what that hormone then does, that ANF does, is it influences urine flow, sodium levels, and it's also kind of that pressure sensor then supplies nerves up to the brain that allow the brain and the heart to communicate with one another, and that kind of helps influence heart rate. So that's kind of what the left atrial appendage does, and then we'll move on to like the next phase where we're talking about therapies for atrial fibrillation. So, I think specifically when I see patients in office, I kind of have to delineate two different things when it comes to AFib, because first, there's therapies for the heart rhythm and heart rate. So when it comes to atrial fibrillation, this irregular heartbeat, we can either try to slow the heart down into a normal range with medicines that you may have heard of, like beta blockers, metoprolol or carvedilol, that patients are on, or another class of medicines would be the calcium blockers, things like diltiazem, verapamil, that some of you may have heard of before. So those are medicines to control the heart rate. Then there are also a set of medicines called antiarrhythmic medicines that try to normalize the heart rhythm. So try to get from that irregular state back to a normal coordinated top bottom type beating. So medicines that would normalize heart rhythm, or what we call the antiarrhythmic medications, are things like amiodarone or sotalol, flecainide, droenderone. It's still available as a branded drug called Multax. So some of you may have heard of that before. So that's kind of on the arm of treating the actual atrial fibrillation. Right? That's kind of the right arm of AFib therapy. The left arm then of that therapy is managing the stroke risk or the bleeding risk associated with AFib. If you remember, I said that mechanically the chambers can't contract and expand as quickly as that electrical impulse happens. And as it comes into that tense standstill, blood clots can form. So we will often, in patients with atrial fibrillation, give medicines that you may have heard of called Coumadin or warfarin, Xarelto, Eliquis, a number of different blood thinner type medicines to prevent blood clots from forming. So there's this two-pronged approach of first, controlling either the rhythm or the rate of the heart, and then treating the consequences of the atrial fibrillation with the blood thinner medicines. So here, talking just to give you a little bit of an idea of the plumbing here, we're talking about this clot forming the left atrial appendage. And then if it were to break loose and go on a field trip, it goes through the carotid arteries, the arteries in the neck, into the brain, and that's what causes a stroke. So a stroke is a blood clot. Well, a stroke related to AFib is when there's a blood clot that gets lodged in an artery that supplies part of the brain, and based on where it ends up in the brain, those are the kind of symptoms or consequences that people have from stroke. So for those of you who are unfortunate to have had either experienced stroke or have a family member or someone that you know who's had a stroke, that it can be different in different people. Some folk can have weakness in their arms, some people can lose vision, some people can have difficulty speaking, and that basically the deficit that happens in the stroke depends on where the blood clot lodges. But the important thing to realize here is no blood clot is good blood clot when it comes to stroke, and so we want to protect people from that completely. So when it comes to predicting who's going to have a bleeding event or a blood clot event, we actually have a couple of calculators that we use to kind of assess patients' risk. And so the risk of developing a blood clot with atrial fibrillation is calculated based on this study that was done that created something called the Chad's VASC score. And what that is, it's a series of risk factors that are additive to give us a sense as physicians of how at risk is the patient in front of me of developing a blood clot. So when you look at these factors, heart failure, so weakening of the heart muscle, hypertension or high blood pressure, age greater than 75 puts you at risk, diabetes, having had a prior stroke, any vascular disease, meaning any sort of blockage in the leg arteries or the carotid arteries that supply the brain, age 65 to 74. So there's a higher risk after the age of 75, but still there's a risk between that 65 to 74 years old. And then female patients are at a higher risk of blood clots than male patients. So we look at these measures and we add up the score on the column here. And then based on that, a score of 1, 2, 3, all the way to 9 kind of gives us this predictive incremental risk of what is the risk of the patient in front of me here in clinic of having a blood clot. And the guidelines right now state that anybody who has a Chad's VASC score of 1 or greater should be on some degree of blood thinner. And that doesn't mean aspirin anymore, unfortunately. People used to use aspirin in this situation a lot, but now we've shown that the safety of these newer agents like Xarelto or Eliquis are such that patients, even with a score of 1, deserve to be on blood thinner to protect them from that risk of stroke. Now, the traditional therapies for this, as I mentioned, are blood thinner medicines. So we've referenced them a couple of times, Coumadin or warfarin, which people will often remind me are rat poison. So that's what's used in rat traps. So this is the cutest mouse I could find in a little teacup to kind of disarm the worries about being on rat poison. But you know, it essentially works by causing animals that are in these traps to bleed to death from eating the pellets that have the blood thinner in them. Now, obviously, we don't use it to that degree in patients, and that's why if you're on blood thinners like Coumadin or warfarin, we're checking what's called your INR, or the level of blood thinning, if you will, on a pretty regular basis. And now there are these new drugs called the direct oral anticoagulants, so like Xarelto or Eliquis or Pradaxa, that are used to treat that blood thinning concern for patients, to put them on blood thinners to reduce that risk of blood clots forming inside of the heart. Now, I mentioned that scoring that we have for patients to kind of calculate the risk of blood clot forming. On the opposite end of the spectrum here, we have what's called a Has-Bled score that looks at calculating the risk of bleeding complications. Because obviously, if you're on a blood thinner, you know, your blood is going to be thin. We need to worry about, well, what are the negative consequences of being on a blood thinner? So things like bleeding in the brain, like a ruptured aneurysm, or internal bleeding from the stomach, what we call a GI bleed, bleeding into joints, or all sorts of different things that can happen when you're on a blood thinner. And if you look at the risk of bleeding here, things like hypertension, stroke, age over 65 are kind of the same things that are associated with the risk of bleeding, right? Or the risk of blood clot, rather, right? So the same things that put you at risk for blood clots forming also put you at risk for bleeding. And unfortunately, up to this point, we really didn't have much other than kind of hope and prayer to kind of keep patients who are at a high risk of bleeding complications from bleeding when they needed to be on atrial fibrillation. So it would often be this really kind of uncomfortable discussion that patients would have with docs saying, well, you know, Mr. Jones or Mr. Smith, Mrs. You know, Atrium, whatever your name might be, I know that you have a high risk of blood clots forming and there's a high risk of bleeding. So we're just going to watch you and see what happens, right? And unfortunately, that was the state of the art for many, many years until the Watchman device kind of came into play. So I kind of put this picture in here to give some idea of perspective. But when we look at the left atrial appendage in most patients, it's about the size of 2/4 of your 2/3 of your pinky finger. So imagining we're treating 100% of the body for something that's about 0.1% of the area, the surface area or the volume of the body. So you're putting this whole thing at risk for this very feared complication that happens in a really small part of the body. And so enter now, Watchman Flex. So there must be a better way. And I think that one of the great things about being a cardiologist right now is that we have all these devices that are actually game changers for folks. And Watchman is definitely one of those that allow people to have the protection that they need from stroke without that risk of bleeding. And that becomes kind of a big deal. So this is what the Watchman device looks like. I don't know if you can kind of see it on the camera, but it's a spongy device. I tell people it's almost like a little cocktail umbrella umbrella that kind of goes in. We'll see a video of this shortly, and we expand it to kind of fill the cave of that left atrial appendage. So I tell my patients it's like one of those old Hardy Boy books that you read growing up, where they go in the cave to chase after the criminal or whoever it might be, and then a big boulder kind of plugs up the opening, the entrance to the cave, so they have to find a back way out, right? So what we're doing here basically is we're taking that windsock or that chicken wing or the cauliflower appendage that we saw, and we're plugging it up. And you see on here that there's this fabric, this white mesh on there that sits over the 3/4 of the device. And over time, as we'll see in the video here in a moment, skin cells actually form on that mesh to exclude that area. So in a sense, what we're doing is putting that boulder in front of the entrance to the cave so that blood clots can either get in or get out. And that is the benefit here. And that's what allows us to take the risk of blood clots to basically no different than being on the blood thinners, but now we've negated that risk of the blood thinning medicine. So things like the brain bleeds and GI bleeds don't become an issue. So this is a video that I'll play, and I think things will be a lot more concrete once you take a look at it. So I'll let this play, and then we'll take some time for questions afterwards. So hopefully you can hear this. Here we go. Oh, let's try that again. There we go.
To perform the implant, the physician accesses the patient's femoral vein and, using a standard transseptal access system with a puncture needle, crosses the septum to reach the left side of the heart. Watchman Flex is designed for precise placement in the left atrial appendage. From windsock to broccoli to chicken wing. Measurements are taken of the appendage with TEE. Contrast may be injected at any time to help visualize the left atrial appendage. At this point, the appropriate size Watchman Flex is selected. The Watchman Flex ball is formed. The fully rounded ball is designed to safely advance and maneuver within the left atrial appendage. Watchman Flex has full recapture, reposition, and redeploy capabilities for precise placement. Dual-row precision anchors designed to provide optimal device engagement with LAA tissue for long-term stability. Reduced metal exposure and long PET fabric designed to reduce healing time and reduce thrombus formation. Once in place, the device endothelializes to seal off the patient's left atrial appendage.
So I think that the animation kind of helps kind of get a better understanding of what it is that the procedure is and what we're doing. Oops, what's going on here? Let's get back to our presentation. All right, there we go. So I think that kind of helps in terms of get a more concrete understanding of what the procedure is and what we're doing. They kind of mentioned in there briefly, so the workup or the evaluation for this is pretty straightforward. We do what's called a transesophageal echocardiogram, the esophagus being the tube that connects the mouth and the stomach. Anatomically, the heart sits right in front of the esophagus, so we can get very sharp and clear pictures of the left atrial appendage, which you can see here being measured. And so the device comes in 5 sizes, so we're able to figure out what is the best sizing of the device for whatever patient we're doing at that time before we start the procedure, to give us a good understanding where the start should be. We do transesophageal echo. There are some centers that do CT scans of the heart, CAT scans of the heart. I personally like to avoid excess radiation for patients if possible, which is why we do the ultrasound. But either way is equally helpful to kind of help give us an idea before we get in for patients. Is this going to be a successful procedure? What are the pitfalls? What are the things that we have to watch out for? These structural procedures, I kind of tell my patients, are really about 80% to 90% completed before we've even started the procedure, because we have all this imaging available to us to kind of understand what we're getting ourselves into, what sizes of device we need, where are the sticking points, what are the things that we need to go in and treat, what are the things that we might need to avoid. But we have a great idea before we get in of what we're dealing with. In terms of indications for the Watchman device, so as it's approved by the FDA, it's indicated to reduce the risk of thromboembolism or blood clot forming within the left atrial appendage, that sac at the top of the heart, in patients with AFib not related to heart valve issues, who are either at an increased risk for blood clot based on that CHADS VASC score that we talked about, are deemed suitable for warfarin, meaning that they need to be on some degree of blood thinner, and have an appropriate rationale to seek some other reason for therapy for warfarin, taking into account the safety and effectiveness of the device compared to the blood thinner medicines. People who are not suitable for Watchman. So number one, at this point, patients say, I don't want to be on Coumadin, unfortunately, or I don't want to be on Xarelto, unless there's some significant lifestyle factor. So we had a patient who was in a high-risk occupation, that putting him on blood thinners would have to force him to kind of quit his job. Obviously, we don't want somebody to have to quit working if they're still able to work. And so, we're able to use that as an exclusion sometimes. Patients who are at a low risk of bleeding, so we talked about that has blood score. So people that haven't had any bleeding concerns up to this point are not yet suitable. If there's a reason other to be on, other than atrial fibrillation, to be on blood thinners. So for instance, if you have a blood clot in your legs called a DVT, or a blood clot in your lungs called a pulmonary embolism or PE, that would not be a reason for the Watchman device. If you have a metal heart valve, a mechanical heart valve, those patients need to remain on Coumadin therapy because other rounds of blood thinning therapy don't work. But that's also the reason for their need for the blood thinner is not related to an AFib related clot. And then finally, if in the rare patients now where the anatomy of the left atrial appendage is not amenable to placement of the device. So I mentioned how there's 5 sizes of the device. Sometimes, unfortunately, patients either have too small an appendage or too large of an appendage where this doesn't fit. And again, generally with the transesophageal echo that we do as part of the workup, we would have a better understanding of that before we actually did the procedure. So expectations, whenever I do any sort of procedure for patients, I always want to make sure that we have a real understanding of expectations. So number one, I think the thing that's the most confusing for a lot of patients is that the Watchman device does not treat the underlying atrial fibrillation. It just treats that blood clotting risk, right? So if you have AFib, your physician, your electrical specialist, your AFib specialist might talk to you about ablation therapy, where they go in and try to zap out those areas of the heart. That's treating the atrial fibrillation aspect of it. The Watchman device treats that blood clotting risk part of the atrial fibrillation. With the Watchman device, the stroke risk is not 0, so it doesn't completely reduce your risk of stroke, but what it does is it takes the risk of stroke to the same level of being on the blood thinner would. So even if you're on a Xarelto or Coumadin or Pradaxa or Eliquis, any of these medicines that we use, even if you're on those blood thinners, there is a risk of developing blood clot. But the Watchman device basically takes to that same level as being on a blood thinner would, without that risk of bleeding. And then finally, once the device goes in the video, they kind of briefly talked about it, and I mentioned as well that a layer of skin cells forms over the device. That takes about 45 days or so to happen. So after the device goes in, patients that have a Watchman implant do need to remain on their blood thinner for at least 45 days after implant. And at that 45-day mark, we do a repeat transesophageal echo, or that ultrasound through the esophagus, to interrogate the device. We look at it from different angles to make sure that there's not blood flow getting through. And in the clinical trials, the patients, I think it was upwards of 98% of patients were able to come off of blood thinners once the device was in and sealed at that 45-day mark. So it's a very successful device, but there are some patients that unfortunately, for whatever reason, do need to remain on blood thinner therapy. So this is the team that we have here at Mission. Great team to work with. This was actually after our first implant, which was now about a couple of months ago, 2 or 3 months ago. You can see me. I'm the incredibly kind of less tall gentleman in the picture in the front. Apparently we hire only people that are taller than 6 feet here. To my direct left there is Dr. Tiongson, who many of you that get your care here at Mission might know as one of our electrical specialists. Then we've got a number of, a number of mates here. We've got folks from the cath lab, from the imaging area that are kind of helping out with this. This is us when we're not in our covered up sterile attire, kind of going from left to right. Chelsea and Taylor are our coordinators. So if ultimately you end up, or someone that you know ends up getting a device, you'll certainly interact with them. They help navigate all the testing and everything that needs to be done. Next to me then is Dr. Tiongson, who's one of our electrical specialists. Unfortunately, he's in procedure right now. He said he tried to make it here, so hopefully he can kind of come to catch the tail end of this if possible. Then myself, behind me flexing, is Rick from Boston Scientific. He's one of the product specialists. Next to me is Dr. Doshi, who's one of our partners from Providence, St. John's, and Santa Monica, and he is actually the world's leading expert in the Watchman device. He's put in, more than anybody on the planet, literally more than anybody on the planet. Just happens to be one of our partners in the Providence network, so he was able to come and proctor us for our first couple of cases. Next to Dr. Doshi is Dr. Koplik, who's one of our imaging experts. So she's in with us during the procedure, looking at the device as we're deploying it, making sure that it sits well, getting our measurements, and making sure that the device is safe to release. And finally, there's Ryan Flanagan, also a product specialist for Boston Scientific, and kind of making sure that we have the supplies that we need, and keeping us honest with the use of the device. So that's kind of the overview. Like I said, Dr. Tiongson is the electrical arm of this. He's our Afib expert. I'm the interventional arm of this. Here are our office numbers. Certainly happy if you have questions right now to field them, or if you want to set up an appointment with any of us to kind of in person discuss, whether you would be, or your family member, whoever might be a good candidate for the Watchman device. We would be happy to discuss that with you.